Today I'm going to talk about multi-modeling planning scenarios for public health and talking about 3 years of work on the COVID-19 scenario modeling hub. So this is really, I'm presenting to work on the, I'm presenting work on this, in these results, but really because this is a hub, it's actually the work of a huge number of people and institutions who've contributed to it. And none of this would have been possible without them. And I'd also like to particularly highlight the help of Cecile Vaboud and Emily Howerton, shown below, who really played a big role in a lot of what I'm going to show you. And particularly Emily drove a lot of this. So to start with some motivation, I'm thinking about to why we created and have this scenario modeling hub. So how do we use models in the pandemic? And I think whenever we come to this idea of mechanistic modeling or disease modeling, we confront one of two attitudes. Either people feel like we should be Nostradamus and be able to predict the future with 100% accuracy and without, and exactly, and they treat us like we're some sort of oracles, or they think or quickly progress to feeling that people who project diseases are just the proverbial monkey throwing darts at the stock pages and really doesn't provide any additional information. And of course, we ourselves always feel like we're Cassandra, telling people the bad things that might happen and being ignored. So why is there this dichotomy? And it's something I've thought a lot about over the years. And I think I have a couple hypotheses about it. And one of the hypotheses is one that's hard to do something about, but it's that models are most needed when we have the least information. And that, I think that comes to this fact that, if you have a lot of examples or something, like if you have hundreds of flu seasons or going to more typical epi, tens of thousands or millions of cases that have been studied, you don't need a mechanistic model. You don't need to reason from core principles about how diseases transmit or how people behave in order to make a prediction or understand what's happening, because you can use classical statistics and that's going to be better. The times that you really have to rely most on these sort of mechanistic models of epidemic spread is when you know hardly anything. In, say, February 2020, when we're, staring down the face of an emerging pandemic, and we have no examples to reason from, and we really have to go from core principles. And so, and of course, models are always better if they have more information and more data to fit on. So we're leaning on these models most strongly when they are least well calibrated. But I think a sort of more interesting and addressable reason for understanding why folks there tends to be this dichotomy in how people think about models is that the goals of epidemic models are often lost when they're communicated and interpreted. And this is to say there are a lot of goals of epidemic modeling, but almost always people look at a model and they think of it as a forecast. And often that's not the intention of the model. It's not been designed to do that or to be specialized for that. And as such, when it's either communicated as a forecast or interpreted as a forecast, it leads to confusion and mistrust. So I like to, with this in mind, I like to think of there really being 4 broad uses of epidemic models. And of course, there's a lot of ways you could chop this up, and this is just my categorization, and a lot of uses of models sort of fall in between these. But I think these broad uses capture a lot of the ways people use them in help us understand some about communication. So one is theoretical modeling, and that's what type of emergent behavior is produced by disease systems with different properties. And I'll go into these a little bit. Then there's inferential modeling, which is sort of how we approach statistics. What is the true nature of disease processes that are producing health outcomes? Then there's strategic models. How do you really focused on how we make decisions and how will for instance, how will the epidemic unfold under different control strategies or various conditions? And finally, is forecasting, which I think is what people most commonly think about, but in some ways is the least interesting. How will an epidemic unfold in the coming weeks or months? So let's dig a little bit deeper into these, just to give you examples of what I mean. So for theoretical modeling is like what type of behavior is produced by disease systems with different properties. So this really gets to ideas like, work like this, great couple of papers here by Shweta Bansal and others, where they look at, they're looking at different types of networks and looking how epidemics will spread in those networks, and single epidemics or more, or multiple ones. And this is really important for understanding for our basic understanding of disease processes, but it's not, necessarily trying to tell us what's going to happen in the individual population. But sometimes people take these kinds of models and try to apply them to real populations and make forecasting. So I think this is a prime example from the pandemic where taking, these sort of theoretical models, Gabriela Gomez and others, put out these, in like mid-2020, put out these papers and these arguments that, oh, the pandemic was about to go away because the herd immunity threshold was much lower than we thought it was because of the way people mix socially. I think this is something that we now know not to be true, but this had a big impact with people saying things like, what if herd immunity is closer than scientists thought in the New York Times? But I think a large part of what's going on here is people were taking this very theoretical model and applying it as a forecasting or strategic model without doing the right type of analysis of what we know, the uncertainties were and the like in applying it. The second type of epidemic model, in many ways I find it the most interesting, is inferential modeling. What is the true nature of disease processes that are producing the observed health metrics? And these types of models, are where we use like a combination of statistical approaches, and our understanding of how the disease works to do something to understand or to create inferences that help us understand how transmission works and key properties of transmission. So here's an example from early in the pandemic where Hay and colleagues looked at transmission pairs or putative transmission pairs and used that to estimate the serial interval or time between generations of infections, as well as the incubation period of the infection and when people were likely infectious. Here's other work that also takes an inferential approach that attempts to say that, actually we did, that used serological data for households in Switzerland, looking at the number of people infected in households, and was able to estimate that if we look at within household transmission, there's about a 17% chance of being infected by a housemate, that it did appear that children, but only children under 10, were less susceptible, which was an important debate at the time, only 7.6%. And then the oldest individuals were more susceptible. But then when you looked at the probability of being infected outside the household, that not shockingly, in the midst of a pandemic where people are doing lockdowns and social distancing to control spread, it was only those working age adults that had to leave their homes that were really that were most susceptible. I'll skip that. And then, so a third kind of modeling is, or a use of modeling, is strategic modeling, where we're asking how an epidemic will unfold under different control strategies and work under various conditions. And this is sort of where the rubber meets the road in terms of trying to inform policy. And you know, people have seen many models like that. People have seen, you know, have done a lot of modeling like this, and it's sort of what I'll be talking about today. But here's a very, you know, a very high profile example, once again, from early in the pandemic, where we have these sort of strategic models from Imperial College, where they're showing how different control strategies are likely to impact the epidemic curve of SARS-CoV-2 over different times, and how they can affect the shape of the cases and how many cases we see. And I think, you know, it's important to realize, like, this is not a forecast, right? Nobody, you know, if any, nobody, like, with any upstandingness would make a projection of a single line and call it a forecast. This is not exactly, this is a very simplified view of the epidemic and what might happen, but it's really there to help us understand how different measures might reduce the spread and exactly what the strength of interventions needed would be to sort of halt things in their tracks. And then, of course, finally, there's forecasting, which we'll talk about a bit more, where we actually attempt to say, okay, we're looking at these incident hospitalizations, and we're at this point, what are they likely to look out in the coming future, sort of your weather forecasts. And yeah, and we'll come back to these and talk about these more. But I think one thing to keep in mind is that no matter what their immediate purpose, whether it be theoretical, inference, strategic, or forecasting, epidemic models are ultimately there to help us plan. That's how we inform public health, or how we improve public health through modeling, is by making planning. Nobody, you know, directly benefits from the existence of a model of how a disease is going to unfold. We only benefit if that model improves our ability to plan for the future and prevent cases that way. So with that in mind, I'll talk about a type of strategic model, in particular, scenario planning models, where we focus on scenarios. And so what are planning scenarios and why do we need them? So, or in other words, why not just forecast? Well, first, models are not oracles, right? This is a quote from Epidemiology. Any model is providing an answer that is conditional on certain assumptions. So that is that we can take a set of assumptions and we can project into the future, but we are only projecting under those assumptions. So, you know, we can, for instance, help people plan if those assumptions are true, but we can't give them accurate numbers if those assumptions are wrong. And because we don't have a perfect representation of the world, they're inevitably going to be wrong. And this becomes really important when we think about, like, the length in which we can project in the future. You know, because we have the data of now, and because, you know, diseases and trajectories tend to follow, you know, reasonably statistically well-behaved patterns, even if we don't put in mechanism, we can generally forecast, you know, a couple weeks in the future, a few weeks in the future, with some accuracy, depending on the outcome. Much like we can, you know, generally provide a forecast for the weather, you know, 10, 12 days in the future. But, you know, as we understand for the weather, you know, the certainty in that forecast goes down as we go further into the future. And that's the same thing is true for infectious diseases. And as with weather, we reach some point where we can't really forecast reliably at all. So for weather, that, you know, that's around 2 weeks in the future, after which time it's hard to do much better than a seasonally adjusted average for a forecast. And that's where we get into the realm of projections. So that's where we need to make some stronger conditional assumptions or scenario-based assumptions on future things like vaccination, NPIs, the non-pharmaceutical interventions, that is, the emergence of new strains, and the nature of the disease, to project further, recognizing that this is more a planning, something that can help with planning and decision making, and is probably not going to be accurate as a forecast because of our strong assumptions are never likely to be exactly true. And we have to do this. Like, we can't just rely on forecasts, because all the important planning decisions, none of those or very few of those are happening on the time scale of a week or two, right? For instance, this has no significance beyond being the first thing that popped out of Google when I searched, that wasn't federal, when I searched for budget planning cycle. And this is the San Francisco budget planning cycle. And you can see it's almost a year-long process. So people are submitting their budget requests and making estimates about what they're going to need in the next year, 6, 9, 10 months, before they'd actually get the funding, before the events that they're actually, a year or more before the events they're actually planning around. And that means they need information that can help them do that planning, even if that information is not perfectly accurate. But it needs to be somewhat reliable. So scenario planning models are models that attempt to project in the future in a planning time relevant to other types of planning, and are based on a set of assumptions. And as planning scenarios is what we're trying to produce in the scenario modeling hub. So that's sort of why we're focused on these scenarios, these planning scenarios. But why hub? Why are we a hub? And so now I'm going to talk a little bit about hubs as an approach to predictive modeling. So here's a quote: ridiculously overconfident and wildly unreliable. So this is about models, but it's not about epidemic models. This is about weather forecasting models before the era of ensembles. So you may not know this, but every single weather forecast you see is pretty much an ensemble of multiple models. It is, so when you see something like this, this famous and famously misinterpreted, cone of uncertainty for a hurricane or a tropical storm in this case, trajectory, what you're really seeing is a summary and an ensemble of a bunch of different models. And you can see that, like, most of these models are sort of going along the trajectory of that original cone, but there are one or two that have this, going off to the north or the northeast and hitting Mexico. And those models are more or less ignored by the ensemble, but sometimes they might be important contributors. So once weather forecasting embraced this approach, it became much more accurate and much more reliable. And this has been seen across many, many fields. So the Forecast Hub, has taken a similar approach for forecasting. This is sort of a parallel effort to the Scenario Modeling Hub. So when you see things like this, they collect a ton of forecasts. And if you look at all of those forecasts, this is submitted to the hub. This is what you get. And you could rightly look at this. And people have looked at this and said, well, infectious disease forecasting is useless. This is spaghetti. How could you possibly tell what's going to happen across all of these models? And true, that's true for all of the models if you looked at the models individually, they sort of encompass what happened, but many are way off what's happened. But if you look at their ensemble, if you look at the sort of sum of those models, the sum information in those models from the hub, you actually get a very accurate forecast of what's going to happen in the next coming weeks. So the hub, gives us the power, and importantly, we'll get to that. And one thing to say is like, okay, I picked a place there that, was fairly good, but this high performance of the hub is something for deafs that's been seen throughout the pandemic. And you can kind of see that here while on some weeks it might be outperformed by one or two individual models, the hub shown here in red and all the individual models are in gray. There is no week where there's no model that consistently outperforms the hub. Here, lower score is better. So the red is the only consistently well-performing model. And you can't really tell it from this figure. But models that are in some periods the best performing, in other periods are often the worst performing. That's not to say hubs are a panacea. For instance, even the group of models has had some difficulty forecasting hospital or cases versus deaths around downturns. So the other reason for a hub is more basic. So we do get better forecasts or better predictions when we have a hub, and we believe that to be true for having better planning scenarios in addition to having better forecasts. But we also do something a little more basic. So early in the pandemic, we're talking March, April 2020, you could go out there and you could find a model, hundreds and hundreds of models, and you could pick out a model showing you almost anything. So in the bottom left here, there's sort of the famous IHME model that goes up and comes down and shows things basically gone by August. On the right, some modeling we did for Maryland that showed things going up and then going down and then coming back after lockdowns are released. Then there's some modeling from UT Austin that shows similar things up there. But all of these are very different. And the thing about these models is that they're all they may or may not differ scientifically in terms of their baseline modeling about the disease dynamics, but they're all making different assumptions about how people are going to respond. For instance, the IHME model has lockdown, or strong social distancing measures occurring throughout the summer, whereas some of the other models have different that being released and different levels of control happening after. And so these may not differ scientifically, but they differ in their assumptions. And this leads to what I like to call the choose your own adventure phase of pandemic modeling, where you could just basically go out and pick a model that showed what you wanted, but it was because that model was making a very particular set of assumptions. So another point of a hub then is just to get everybody on the same page, have everybody model the same thing. So any differences in trajectories represent different legitimate differences or points of scientific agreement or disagreement about what will happen given the scenarios, and are not disagreements about the scenarios themselves. So with that in mind, we created the COVID-19 scenario modeling hub. So I contacted some colleagues back in December 2020 and said, I think we need to do this. And we created the hub. So the hub, what is the COVID-19 scenario modeling hub? It's a multi-team effort aimed at creating and modeling planning scenarios on the mid to long-term COVID-19 situation, and projects cases, hospitalizations, and deaths. And scenarios have been developed in close collaboration with government agencies and other stakeholders. For instance, we talked to ACIP a lot about our scenarios, who make vaccine choices early on. We talked to the White House, other parts of the CDC. To date, actually, I guess I thought I'd updated this slide, but today there have been 17 rounds, 14 of which are public, of the COVID-19 scenario modeling hub. We'll talk about the evaluation of the 16 here today. And we generally get 5 to 10 teams submitting per round. The process by which the scenarios are created is sort of can sort of be captured here, and the projections are created. So we start with, sort of taking a survey of the land, getting questions from various stakeholders, looking on the horizon. Are there new variants that might potentially be coming? Interventions that are of particular concern or that we may be considering using or stopping using and stuff. And then using those, we generally come up with two axes of uncertainty, that define the scenarios. So for instance, one might be whether or not we increase vaccination, and another might be whether or not we see a new variant. And so we come up with this sort of 2x2 grid usually, though we've had bigger grids and like in round 17. And out of that gives us 4 scenarios at the intersections of those axes. And then we, work with the teams to refine the models and scenarios. We need to define them in a way people understand them and their models can do them. And then people do their model fitting and projections, and we get projections from individual teams. And then we go through a process of quality checking, ensembling, and discussion to come up with ensemble projections that represent the sort of consensus or gestalt of all the teams. So this is what this looks like over the first 16 rounds. So the black line here is what we actually observed, and here I'm showing all projections from the hub of scenarios, regardless of how plausible they were. And then, and then for reasons that I'll explain in a minute, they're truncated. We truncate I'll explain now. And then we've truncated scenarios that didn't anticipate that there might need to be a major variant or a new variant. We truncated them at the emergence of the unanticipated variant, because at that point, any projections they made become irrelevant. So we alpha, delta, and Omicron. And by Omicron, we'd kind of learned our lesson, in every single scenarios we made had some anticipation of potential new variant or continued viral evolution. So we've looked at like a lot of different factors over the course of the time, and they sort of reflect the changing views of the pandemic. So early on, most of the focus, while there was some focus on variants, most of the focus was on non-pharmaceutical interventions, or NPIs, and first vaccine supply. And then very quickly, we shifted to vaccine hesitancy being a bigger factor than vaccine supply. Then we started thinking about vaccine uptake and more transmissible variants. We sort of get the march of new variants through Omicron. And then we start thinking about boosters and waning, and sort of thinking differently about more variants. And then our final round 17, which we call the mega round, we projected, in all these previous ones, we projected out 3 to 6 months. And in round 17, we projected out for 2 years and really looked at a larger intersection of potential vaccine policies and the like. Our projections, these planning scenarios and planning projections, have been used by a wide variety of stakeholders, including ACIP, FDA. I know because they asked a question. Don't ask me how they're using it, but I know the Hartford has used our projections in the past. We've generally talked to NPR after any new projections come back. So we've had a decent amount of impact, and this is sort of a little bit of a timeline of some of the presentations. This goes through 2022 that we've made over the course of time. I think some of the most impactful have been to the ACIP. So I know that our projections played a pretty big role in the approval of the first reformulate, or the recommendation rather, for the first reformulated booster dose in September of 2022. And this work is continued. This is just slightly less pretty, but longer timeline. And this work is continued, and including presentations to ACIP recently. So just to dig in a little bit about, I've been talking abstract, but this is give you a sense of like what scenarios look like. So we would have, on one side, this is sort of our round 13 scenario assumption. So on one axis here, we have here we have sort of scientific uncertainty by scientific uncertainty. So here we have sort of optimistic waning against protection, because this is a point of major uncertainty, versus pessimistic waning of protection against infection. And then on the other axis, we have a scenario where there's no new variants versus a scenario where there's a new variant. And that gives us our 4 scenarios. And then we come up with projections for each of these. This is for a different round, where the round 16, where the axes were how much booster uptake there was and how much immune escape was. And I think we were firmly in this low booster, high immune escape scenario in the bottom right. And we would generally project out the ensemble. One of the things we realized, sort of moderately early in this process, or about halfway, is that, if you ever show the median line, which is not a good reflection of the uncertainty in the models, and the uncertainty in the future, people focus in on that almost very myopically. So for that reason, you'll notice here the dotted lines are what really happened, and then we just have shaded regions that represent our 50% prediction interval, 75%, 80%, and 95% prediction intervals for the future, sort of giving these cones of uncertainty so that people don't reflect too much on that median line. So we've been doing this for a while. And, one of the things that I'm very committed to and I always think about is anything you do that attempts to project the future and stuff is you should evaluate it. You need to hold yourself accountable to make sure you're doing good scientific work and actually adding value to the world and improving responses. So there's a challenge, though, for doing this for planning scenarios, because by definition, and everything I've told you about this, the exact assumptions of planning scenarios are almost never going to occur, and they're never going to exactly happen. And at best, only one of those scenarios is going to come true. So we have one true scenario and 3 counterfactuals in the 4 scenario things. So with that in mind, how should we go about evaluating scenarios? And I thought a lot about this, and we've gone back and forth in different ways, thinking about decision theory and value information and like. But still, if we want to use the information out there, we always come back to having to do something with what we saw. And so we've come up with a way in which we sort of evaluate the scenario definitions themselves based on bracketing, and then looked at performance on what we're going to call plausible scenario weeks, which I'll define in a little bit, and sort of evaluating those as forecasts, even though planning scenarios very much are not forecast, as our best way to sort of figure out how well we did. And as mentioned, this is work with Emily Howerton, really led by Emily Howerton, and Cecile Viboud also contributed a lot, in addition to the many, many other people. So if we think about these scenario projections as a bunch of conditional forecasts, where we have like the probability of some event, conditional on some set of assumptions, our sources of error can come from 2 places. One is deviations between a scenario assumptions and reality. So for instance, here, if we have a cumulative first dose is administered and we have a scenario that has it going on up at a constant rate, but in reality they deviate, error in any one source of error in any projection based on that scenario is going to be that deviation in vaccination. The second source of error is model calibration given that the scenarios are true. For instance, if we exactly get everything right in the scenarios and project this green line with that uncertainty, and what we actually observe is this dotted line, well, then that error is based on poor calibration of our models or poor performance of our predictive models, not on misspecifying the scenario. So therefore, we do two things to so therefore we have sort of a process for modeling, looking at the scenarios. We first evaluate whether or not the scenario assumptions bracket reality, and then to sort of evaluate our scenarios themselves, and then we compare, we do a retrospective evaluation of performance through this process of first identifying plausible scenarios by comparing their scenario specifications to realized values. So for instance, if we have a reality in this picture, if we have a reality, we have an optimistic scenario and a pessimistic vaccination scenario, and that optimistic vaccination scenario looks much more like reality over the period of interest, that'll be the scenario we say is more plausible and we'll evaluate. We then look at points really just on the alpha, delta, and omicron emergences where an unanticipated variant emerges or it's divergent, and we need to truncate our scenario because anything after that point is really not very informative. And then we go to compare scenario modeling. Then using these two things, we identify a scenario or set of scenarios and a set of weeks where we think the scenario is plausible. So we call those the plausible scenario weeks. And then we just use standard methods for evaluating probabilistic forecasts and looking at, epidemic trends and stuff to evaluate the scenarios over that period. So we've done this for the first 16 rounds of the Scenario Modeling Hub in a paper that it's on medRxiv, but should be published in a peer-reviewed journal, I think next Monday. And we found that for the most part, we did pretty good at bracketing the scenarios where we had things that we could bracket. Things like NPI, uptake or compliance turned out to be really hard to measure. And each of these solid lines is showing how long our scenario assumptions remained valid and we could evaluate. So if we look at those weeks and look at the performance of the individual models, here on incident cases and incident hospitalizations, we find the ensemble consistently is performs best. So all you need to know to interpret this figure is that a bluer or lower number means better performance. And as you can see, the ensemble is consistently one of the best performers among all the models. And importantly, even when a model, say model A here outperforms the ensemble considerably in some round, so for instance, round 5, it's much better than the ensemble. On other rounds, it may be one of the worst models submitted and may significantly underperform the ensemble. So that really points out to this fact that the ensemble, while it's not necessarily always the best, it is the most consistently the best and the most reliable model that we have. And also, we use this ensembling technique called probability averaging or a linear opinion pool. And we've also shown that that ensembling technique tends to work better than other ensembling techniques. If you look at the performance in here, we've highlighted the scenario considered most plausible of the ensemble over time in terms of 95% confidence interval coverage, and WIS, which is that same measure where lower is better. You see that we've had sort of variable performance over time, but particularly in later times, we generally over most of the period get close to 95% confidence interval coverage going forward. Omicron wave was particularly high performing, and Delta wave was particularly poor performing. We'll come back to that. The gray line here shows the performance of the 4-week head predictions from the forecast hub, which in general would have a lot more information to project than the scenario modeling hub because it was projecting much shorter time in the future. And you can see that often, even in periods of poor performance, we were commiserate with the forecast hub projections, though they sort of stabilized in later years. Later times, and interestingly, in Omicron, we actually sort of outperformed the forecast hub. One question is, are we right for the right reasons? Another way of saying that is, when we go and identify the most plausible scenario, is that actually, using our metrics, is that actually the scenario that has the least error? So are we right when our assumptions are right, or would we have been even righter with the wrong assumptions? And if you look at this, you can see that for the most part, the selected scenario or scenarios is one of the highest performing, but there are some significant deviations. For instance, in round 2 here, scenario B was considered most plausible, but scenario A best matched reality. And you see not as stark, but similar phenomena for instance, incident cases in this later scenario here. But for the most part, they matched up reasonably well. So another question to ask is, okay, these are some measures about performance: 95% confidence interval coverage, WIS, which sort of combines how well our mean matches what happened with like our certainty and confidence interval coverage. Do they match our intuition about performance? And this came up really looking at around discussions that I had with folks around this period here. So to zoom in on that, so this is the Delta wave and the immediate wave immediately after Delta. So if you look at the Delta wave, so what actually happened is the black line, and all of our projections are in these darker blue lines. You can see that like the Delta went up far faster than we ever anticipated, and really by any traditional forecast performance metric, we completely bombed there. And then in the round 9, we're a little high, but for the most part, our projections capture most of the trends, and most of the time is within the 95% confidence interval for 9. It's actually a pretty good projection based on traditional forecasts. But when I talked to folks, granted these are different people, one person retrospectively said, oh my gosh, you guys basically got what was going to happen with Delta. And somebody else was like, well, your forecasts for round 9, they were fundamentally misleading. And, and like this, it's opposite on any metric you care to use, right? Like Delta, right? The Delta projections, like horrible 95% confidence interval, horrible WIS. Well, the round 9 projections are good 94% confidence interval, decent WIS. And so by any traditional metric, round 9 is better than the round 7 Delta wave. So this has got us thinking, is it just all about, direction? Is it all about our ability to predict direction? So what we did is we looked and we classified forecasts and what was actually going on into periods of increasing, decreasing, and flat incidence. We then categorized our forecasts and compared our forecast categorization to what was actually observed. And I'm going through this a little quickly just to not run out of time. What we found is that in general, we did pretty good, sort of better than at random and better than if you just continued current trends for periods of decreasing and flat incidence, often substantially better, though we had trouble anticipating increases and actually did quite bad there. If you kind of look at it at observed and projected, when we were projected an increase, we were right 45% of the time. We did much better than at random, but we only captured 24% of increases. So, another way to say this is our specificity wasn't horrible, but our sensitivity was pretty bad. Importantly though, we rarely miss by 2. We rarely would project something increasing when it was decreasing or decreasing when it was increasing. So to wrap up a little bit, I'll just talk about our most recent projections, and I'll go through this rather quickly since I've used up most of my time. So back in the spring, we did sort of a massive projection, largely aimed at informing some ACIP decisions about vaccination. We considered a low immune escape scenario and a high immune escape scenario where the virus was escaping by 20% a year versus 50% a year from our immunity. We considered vaccine recommendations of no recommendation, 65 and over, and what actually happened was all eligible groups. And we assumed uptake would mirror the first booster uptake. So not the first reformulated booster uptake, which was abysmal, but the uptake of the first booster. We found that weekly deaths and hospitalizations were likely to stay within the range seen in 2023, and very unlikely to hit Delta or Omicron peaks. Here we have our projections on the right for the 4 scenarios. I think all booster high immune escape is the one that most matches reality at this point. And you can see that though we missed some of these upticks in the southern states around the end of the summer, mostly the projections have been pretty good and things have remained within 50% prediction interval. And if you sort of break that out by states on the right, that's held. So I'm reasonably confident that this sort of 2 peaks and lower levels will hold minus something unanticipated. We project that peaking activity will peak in the late fall or early winter, so sometime between November and January in each of these years. And that we would see peaks somewhere in the at the like 62,000 hospitalizations per week range at high. Yeah, this is just the same thing another way. In the most pessimistic scenario, we project between April 2023, so it's already a bit in the past, and April 2025, we project 2.2 million hospitalizations and 201,000 deaths. So this is high immune escape with no vaccination versus in our most optimistic scenario, 1.3 million hospitalizations and 122,000 deaths. Perhaps most importantly, that, if we do have vaccination of everybody, we reduce the amount of deaths by nearly both hospitalizations and deaths by around 20% or more in the high immune escape scenarios where I think we are. And we get about an additional 10% reduction compared to recommendations for 65 plus. I'll skip those since I just summarized them and just have some closing thoughts. Planning scenarios play a critical role in the response to any type of infectious disease crisis. And the COVID-19 Scenario Modeling Hub has leveraged the power of multi-team ensembles to provide better planning scenarios and impact policy. I do think there are fundamental challenges to evaluating the validity and utility of planning scenarios, and though we've made our good attempt, I think there's a lot of work to be done here. And we should certainly continue to build on what we've learned through this and other efforts to confront future threats. So with that, I'd like to thank the many, many people who have contributed. I actually need to get an updated version of the slide because there's many more to add, and take any questions.
All right, thank you, Justin. Please join me in, actually thanking Dr. Lessler. So we have some individuals here in the room, we'll see if there's any questions, if anybody has questions in the Zoom, please write in the chat. So I'll get started. So in the beginning of the, COVID, pandemic, I think the model came from IHME, which was very deadly, in terms of death and whatnot. That led to lockdown, global lockdown. So and then again, these were based on assumptions like you were saying. If we have to go back and then evaluate on some of these assumptions, how close or how far away were some of these assumptions?
Yeah, so I think you're actually not referring to the IHME model, but to the Imperial College model.
Yes, I think, yeah. Sorry.
Yeah, the Imperial College model. And I think if you, just a second, let me see if I have this backup slide. So I will say that the Imperial College model, here, I'm gonna stop sharing for a moment and then see if I can find it. And if I find it, I'll share it. But the Imperial College model, I think, given the information that was had at the time, they were actually reasonably decent assumptions, like things like the serial interval and stuff like that. Here they are. Were not, were the reproductive number, they were pretty accurate. I think the things that, and I think there are a few things that they got wrong or underappreciated. One, of course, was how quickly we get a roll of vaccine out. Nobody thought we would roll a vaccine out that quickly. I think another is how quickly the virus would evolve. I don't think we anticipated that we'd see so many new variants so quickly, and that all that first modeling just focused on that first wave. And then finally, I think they underanticipated how well a really, really well-run moderate social distancing and contact tracing program could actually reduce cases. And here's a little slide I have about these models, because I use it for an example often when I give this talk for a different reason. Right, so here, so this is, right, so this is the Imperial College projections along the top of the number of deaths that were projected in each country over 2 years by the end of the pandemic. Now, in May 12, 2020, somebody who didn't like lockdowns said, oh, look at how many deaths we have now. It's nowhere near that number. So clearly the Imperial College projections were BS, and we locked down for no reason. But if you start looking out, if you say, okay, well, what did the Imperial College projections actually look like 2 years out? Well, in the number of deaths. Well, they're still, those unmitigated numbers are still high, but they're much closer, right? Like seeing 40,000 deaths in Canada, 1 million deaths in the US, like that's not looking as different. And then if you look at the Imperial College mitigation numbers, the mitigation numbers are, and I think we did do a lot of mitigation, like they are, they're relatively commiserate, and also suppression numbers, like they're relatively commiserate with what we actually saw in different places. And I think a lot of, it's important, and of course, all of these numbers were with no vaccine, other imperial projections, and we actually did have vaccine. Now it's clear that they were able to do something in Japan, Taiwan, Korea, and a lot of the Asian countries with contact tracing and like other measures that a lot of the rest of the world wasn't able to replicate, and that the projections were far too high for those areas. So it's not to say they didn't miss anything, but they certainly, the planning scenarios, and if you look at the planning scenarios that are more similar to what actually happened, they were decent. So that is to say that probably, probably they weren't so bad in their assumptions. Now, I think the biggest thing, if I could go back in time, the thing I'd want to change is when people looked at the projections from Imperial College, all of these projections, and people we were working with and stuff, they really focused on the forecast part. They really focused on the like left part of the graph, if you're just looking at a graph, right? The early part. And that was the part that was going to be hardest to get right and had the least information that they really needed to know for planning long term. What I always really wanted them to look at, and I wish I tried harder in retrospect, was the right side of that, where you see after summer 2020 it coming back, and it coming back again and again and again as we suppress potentially. Because I think one of the things that happened is everybody was always like, we're going to do this and it's going to get better. We're going to do this and it's going to get better. But really, every one of those things we did just bought us time. And we didn't necessarily use the time wisely to do things like put measures in place so that schools could be, that we didn't have to have schools closed. Do the things that we would have to do to sort of take our feet off the brakes earlier than we did in a lot of places and get back to quote unquote normal faster than we did. And I think had we had more focus on not just the immediate part of the plan, but the fact that we were buying time for the longer term in those early days, I think the last 2 years last 3 years would have been better overall.